Let's move on to joint pathology to talk about osteoarthritis and rheumatoid arthritis. Osteoarthritis is a very common disease. On the Step 1 exam, common diseases will show up in questions very often. Sometimes they'll give you a presentation that'll make you think of another disease, but won't give you that single additional classic feature that gives you a more exotic diagnosis than osteoarthritis. Remember, common diseases present uncommonly frequently, while uncommon diseases present commonly infrequently. Always remember to consider the simple, easy, common diagnosis first, and only go with something more exotic if in fact you're given a detail that makes you truly confirm it. And easier said than done, but always answer the right question at the right time. Okay, osteoarthritis is a disease that is thought to be mechanical in etiology, with chronic wear and tear of joints that leads to destruction of articular cartilage. If you were to stain a slice of someone's OA joint with safranin O, what would you expect to see? A major decrease in the amount of cartilage, because this stain helps to visualize bone versus cartilage. It is often marked by nodules in the DIP and PIP joints called Heberden and Bouchard nodes. Try to keep these straight. I always remembered Heberden goes with DIP joints by saying hip dip, using the H to rhyme with dip. Overall, osteoarthritis is almost exclusively found in older individuals, especially those who are obese, which puts more mechanical stress on the joints. Now, what else could alter the mechanics of a joint? Well, previous injuries or deformities. What will be the patient's clinical vignette? Usually an older individual with pain in the weight-bearing joint after repeated use, particularly at the end of the day. Usually this pain improves with rest. When it's in the knee, it's usually the medial aspect of the knee. What else is classic for osteoarthritis? Well, for one, it's a non-inflammatory arthritis. When we speak more about the different inflammatory arthritides, this will be more clear, but because there's no chronic inflammatory undertone to this disease, there are no systemic symptoms that come along with it. This is very different from chronic inflammatory arthritic disease like rheumatoid. Knowing this about the pathology, do you think we would more commonly use steroids to treat osteoarthritis or rheumatoid arthritis? Good. They'd be more useful in rheumatoid arthritis, in which their anti-inflammatory properties would have a greater effect. So what happens in osteoarthritis? Well, for one, the capsule can thicken and the synovium will hypertrophy. The joint space itself will narrow, with ulcerations developing in the articular cartilage surfaces. This can also lead to bone touching bone directly, leading to sclerosis and bone cyst formation. Finally, osteophytes may form, which can protrude into the joint space or out around the joint space borders. Now, why do osteophytes grow? Well, it's in an attempt to stabilize the joint. The end product of osteoarthritis is a completely fused, bony joint. You'll most likely see a patient with knee disease and narrowing of only the medial compartment of the knee, as seen in this X-ray. What is the first step for treatment? Weight loss and exercise. You can move to NSAIDs and glucocorticoids for non-responsiveness or severe pain. Last resort treatment is a knee replacement. Flash quiz. Which joints of the hand do Heberden nodules affect? The DIP joints. In contrast to a non-inflammatory disease like OA, rheumatoid arthritis is the first of a few inflammatory arthritides that we'll discuss. What makes RA different from OA? RA is an autoimmune arthritis affecting synovial joints with formation of pannus in the joint. A pannus is basically just an overhanging flap of tissue. Clinically, as with many autoimmune diseases, which gender do you think is more likely to experience rheumatoid arthritis? That's right. Women are much more likely to present with RA than men, often younger females. Also, as with most autoimmune diseases, it is important to know some of the key immunologic properties that distinguish this disease from other autoimmune diseases. For one, it's marked by type 3 hypersensitivity. You might remember this from the immunology lecture. This means it's antibody complex mediated. The classic antibody is aptly called rheumatoid factor, or RF, which is actually an antibody that develops against the Fc portion of IgG. However, only 80% of the people with this disease are actually positive for rheumatoid factor. So while it's important to know, it is not necessary to make the diagnosis. There is another antibody called anti-CCP antibody, or cyclic citrullinated products. These CCP molecules are thought to be involved in inflammation that happens in the joints of people with RA. While the anti-CCP antibody is less common, thereby making it a less sensitive indicator, it is also more specific, meaning if it is positive, you are much more likely to truly have rheumatoid arthritis. Also, there is a segment of the HLA molecule, DR4, that is associated with RA. Now, how will your patient present on the boards? Well, she'll describe morning stiffness for greater than 30 minutes that improves slowly with use or by running her hands under warm water or perhaps even after a shower. Patients with OA will have morning stiffness as well as a result of not moving all night while asleep, but this often resolves in less than 30 minutes. Which disease improves with rest? Well, that's osteoarthritis, not RA. Also, RA tends to be symmetric, so if certain joints in the hand are affected, then the same joints of the opposite hand tend to be affected as well. What else should you look for when you're thinking of RA? Systemic symptoms. Systemic signs will include fever, fatigue, weight loss, but can be more subtle with pleuritic chest pain representing underlying pleuritis, or vague chest pain indicating underlying pericarditis. Just to double check here, do you know what we mean when we say pleuritic chest pain? Right, it's chest pain that hurts when you breathe. Use these differences to choose between the two on Step 1 questions. First-line treatment involves use of NSAIDs to decrease inflammation. Selective COX-2 inhibitors such as celecoxib are also frequently prescribed, especially if the patient has a history of GI issues with NSAID use. Glucocorticoids and other drugs that modulate the immune system may also be taken by these patients. DMARDs are the classic treatment for RA, and if you see a TNF-alpha inhibitor such as etanercept or infliximab, it's likely the right answer. Flash quiz. OA presents with stiffness at what time of the day? Classically, it's late in the day after exercise. Let's take a closer look at the joint in RA. Here we see increased synovial fluid and pannus formation. The key here is that the joint is being degraded instead of forming osteophytes and filling the joint space as seen in OA. Clinically, the physical exam and radiographic findings can be very telling for RA. What would you look for on exam? You may see subcutaneous nodules, which would appear like small bumps, often not incredibly large, but usually multiple are apparent. These rheumatoid nodules don't only have to be in the skin, but can also be in the lungs or other viscera. So if you're hearing about joint pain in the vignette and see a chest x-ray with bilateral hilar fluffies, consider rheumatoid arthritis as the answer. Exam of the joints themselves should focus on the hands, particularly looking out for ulnar deviation and subluxation of finger joints. As you may imagine, chronic inflammation within the fingers will lead to many frank deformities of the joints, such as boutonniere deformities seen in these hands. Within the fingers themselves, MCP and PIP joints are often involved, but characteristically the DIP joints are not involved, in contrast to osteoarthritis. Flash quiz. Which disease is more likely the result of, instead of results in, deformity of the joint? OA or RA? Osteoarthritis. So let me ask you, which would you rather, OA or RA? Well, if it were up to me, I'd definitely choose osteoarthritis. It's a mechanical problem and can be fixed mechanically in most cases with a joint replacement. Rheumatoid requires a complex regimen of medications with some pretty nasty side effects and comes with a package of autoimmune disorders.